Forget frequently asked questions.
Common sense, common knowledge, or Google.
How about advice from a real genius? 95% of people in any profession are good enough to be qualified and licensed. 5%
Go above and beyond.
they become very good at what they do, but only
0.1%
are real geniuses. Richard Jacobs has made it his life's mission to find them for you. He hunts down and interviews geniuses in every field: sleep science, cancer, stem cells, ketogenic diets, and more. Here come the geniuses. This is the Finding Genius Podcast
with Richard Jacobs.
Hello, this is Richard Jacobs with the Finding Genius Podcast. I have a returning guest, Joseph R Masci. He's a clinical professor. He deals with medicine and infectious diseases, environmental medicine, and public health, more so these days. He had written several books on HIV and worked on it quite extensively. That's what I wanted to talk to him about today. Although, again, his focus has changed a little bit recently, but he's at Mount Sinai. And Joseph, thanks for coming.
My pleasure. Thank you.
Yeah. If you would, again, it's going back a little bit in your timeline, but tell me about how you first encountered AIDS and HIV and
Sure.
what led you to work on it for so long.
Well, I started my training in infectious diseases at Mount Sinai in 1980, and this was the year where the initial cases of what turned out to be later recognized as AIDS were identified. There were some in New York. I had one of those patients. There were some in Los Angeles. It was originally thought to be confined to gay men. Then it quickly became apparent that that was not the only group at risk. And then over the next few years, what was happening internationally was the identification of the infectious agent that caused it, the human immunodeficiency virus. And locally, what we were doing is creating outpatient and inpatient services for a really quickly expanding number of people with AIDS. And this was at a time when not much at all was known about how to treat AIDS. There were no antiretroviral drugs available and nothing proven to work for about 10 years after that. We were trying our best to prevent or treat opportunistic infections as they came along, but we were also doing a lot of emotional support. And it was a sad but inspiring period for me because many of the patients got very attached to us as staff. We built a staff that was very all-purpose. Together we created what we called the living room, which was a space in the hospital that was furnished as a living room where patients could come 7 days a week and just relax, watch television together. These are people at that point that were largely isolated from their families. And in some instances, we became like a second family. We had monthly memorial services and concerts for them. So that was the first 10 years of the HIV epidemic. It was sudden and it was tragic and it was not really treatable at all the way it is today.
You know, I know the public has heard about AIDS and HIV a lot, but what are some of the basics of it? Like, what are the fundamentals that the public doesn't know?
Yeah, well, I think that, the basics from a medical standpoint are the human immunodeficiency virus type 3 is the causative agent of it. It is transmitted readily through sexual contact and also through blood contact, both through injection drug use and initially through blood transfusions. The transfused blood was eliminated as a problem in the 1980s as they developed screening tests for it, and they began to be able to exclude potential donors who appeared to be at risk for it. So that's the story. That's how HIV was spread. What it does in the body is really quite unique. It's a virus that's called a retrovirus, which means it is an RNA virus that reverse transcribes its RNA into DNA. And it then inserts into the host human cell's DNA. And there it may remain quiet for years before it produces actual clinical disease, averages about 10 years. So the people who we were seeing back in the 80s were coming in with advanced stages of this. So it was obvious that this infection had been spreading back in the 1970s, unknown to anybody at that point. And then the treatments that came along, since as many people know, we have very little in the way of treatment for any viral infection, including COVID now. struggling to find treatment for it. And the same was true of this particular virus. And like virtually all viral infections, once a person has HIV, there is no medication that will get rid of it. The best that we can do is suppress its growth and protect the cells that are most vulnerable to it from getting destroyed. And those cells are called the CD4 lymphocytes, or T helper cells. And one reason why this became so clinically recognizable is when those cells are subtracted from the human immune system, there are certain unusual infections that develop very often. So, for example, pneumocystis pneumonia, which was a very rare parasitic pneumonia, became explosive in the 1980s and became the commonest cause of death among HIV patients. And then other similar infections that were typically seen as rare, sort of zebra infections up until then, became suddenly very, very common, like brain infection with the parasite toxoplasmosis, central nervous system infection with the yeast Cryptococcus, and then other conditions as well as these infections became obvious. Kaposi sarcoma, which had been a kind of a rare indolent malignancy that was seen in elderly men in Mediterranean countries, became a common illness in people with this infection, and it could develop in any part of the body. And it could also be quite aggressive and sort of explosive in how it developed. So we were confronted with a lot of conditions that we did not really have good treatment for. And the treatments had to be developed relatively quickly. And as we were doing that, we were obviously desperately trying to identify antiviral drugs that would actually suppress HIV. And the first of those was called AZT at the time. It's called zidovudine now. And it had been an orphan drug that didn't really have any use for anything. And it was one of the drugs that was tried, and it blocked the enzyme that the virus uses to convert its RNA into DNA. It's an enzyme called reverse transcriptase. And for years, we thought that we were seeing some response to it, but we started using AZT in the mid to late 1980s. It wasn't really shown to be effective at all until the early 1990s, when it was finally shown to be effective in relatively limited populations, particularly among pregnant women, in protecting their developing child. So it was, and this is maybe something that we'll reflect on COVID one day. The treatment seemed to be working in some patients for 5 years. We thought we had something, and in the end, we did not. AZT alone was not doing anything. We were using it in very large doses. It was causing a lot of side effects, and we thought we were seeing a response, but in the end of the day, we were not. So then through the 1980s, similar drugs, these are called the nucleoside drugs, were developed and studied and released. And in various combinations, we learned after the AZT experience that drugs have to be used in combination to effectively suppress HIV and improve the immune system. They were typically used in 2 or 3 drug combinations. These were also very harsh drugs in terms of their side effects, but they actually did work, not as well as the drugs that are used today, but they did. And then in the mid-1990s, there was a major breakthrough when the protease inhibitor drugs were developed, and it was demonstrated that they, in combination with the nucleoside drugs, could be particularly effective. And then the story goes on, and I think at this point,
one quick question here, just very quickly. How do the protease inhibitors work? Because you talked about inhibiting reverse transcriptase, but
right.
How do the nucleoside drugs work, and how do the protease drugs work?
Well, the protease is an enzyme, again, produced by the virus that is involved in cleaving its viral envelope down to the right shape right before it leaves the cell. So if you can attack it at that phase, it's very different from the attack point for the nucleoside drugs, which is in nucleic acid replication. But if you could attack the protease enzyme, that was a completely different mechanism. So that was good. Have 2 different mechanisms, prevent the virus from assembling itself when it was ready to leave the cell. And in combination, they didn't have the additive side effects, protease inhibitors and nucleoside drugs, that the total nucleoside combinations would have. And at the same time, the nucleoside drugs that we were using were improved. They were expanded, and they were developed in less toxic formulations. So by the end of the 1990s, we were using primarily combination treatment with protease inhibitors. One drug that was very common back then was a drug called ritonavir, and nucleoside drugs like AZT in combination with D4T, for example, or 3TC. These are all abbreviations for the long names of the drugs. And then as 2000 rolled around, further improvements in treatment came along. And as I began to say a few minutes ago, what we've reached now is about 40 either combination pills or combination regimens that can be used effectively in HIV. Also, what's happened along the way, we've developed very precise measures of the amount of circulating virus in the blood, the so-called viral load. And we've learned a little bit more about the immune response to HIV and what it takes to sustain the immune response. So we can test for viral resistance now. We start treatment very early. Initially, partly because the drugs were quite toxic, they were reserved for people who were really at the advanced stages of HIV. A typical CD4 count in a normal host is between 500 and 1200. We were holding off until everybody was holding off until the CD4 count fell below 200. But in the last few years, it's become obvious that treatment at any stage is advantageous and is actually preferable to waiting that long to achieve complete viral suppression and complete restoration of the cellular immune system. So now the projections are quite amazing that an individual at age 20 who gets HIV and is effectively treated has about the same life expectancy, about to age 70 something, as someone who never had HIV in the first place. So we're very good at suppressing this infection, but the downside is you have to keep on the medicines for life at this point. The efforts have also included attempts to create a vaccine to HIV. That's been completely unsuccessful so far, and ways of preventing infection, so-called PrEP therapy, to prevent infection after exposure, where people can take a cocktail of antiretroviral drugs to prevent transmission or stop transmission before it causes infection. And these strategies are very, very good. They're have been life-saving, and preventing infection is actually simpler than we would have thought it would be using the right combination of drugs. It was a study in Italy about 10, 15 years ago now, looking at heterosexual partners, one of whom was HIV positive and the other one was not. When the HIV positive one was given antiretroviral therapy to suppress their viral load to undetectable, they could not transmit HIV infection anymore. So in this day and age, as we're still hopefully one day going to see a vaccine, because of the incredible effectiveness of the current treatment, our job is to be sure that people who, that everybody is tested for HIV, and anyone who is found to be positive is strongly encouraged to enter care, because we can save their life. And it's dramatic. At Elmhurst, we were following about 1,500 HIV patients in our clinic, and over 96% of them have undetectable viral load and are fully immune reconstituted because of the various drugs that they're getting. So it's been an amazing turnabout.
Yeah. I'd like to ask you about some of the mechanisms of the viral action specifically. So, what happens? It enters the cell and essentially then what? At what point does it endogenize into the DNA? What does it look like?
It does that routinely. It releases its RNA into the cell. It has the enzyme reverse transcriptase in the virus, and it reverse transcribes, because typically DNA is transcribed into RNA. In the case of the retroviruses, the RNA is transcribed into DNA, which then inserts into the human chromosome. And there it can remain quiet for many, many years. It's very rare for anybody to get immune damage from that quickly. There is an illness that comes along with that, so the so-called seroconversion illness, at the time where someone is infected with HIV long before they have AIDS. But that illness is rather nonspecific. It's fever, rash. Some people don't get any of it. Some people don't notice it when they do have it. But it's an amazing illness in that it produces this acute phase, which is fairly harmless. Then it goes underground for a decade. Then it starts producing the illnesses that are caused by the destruction of the immune system.
If you like this podcast, Please click the link in the description to subscribe and review us on iTunes.
Interesting. So it becomes part of our own DNA. Its DNA material literally becomes part of our DNA.
Right. And then, of course, it gets replicated as our cells are replicated.
How does it remain independent and active once it integrates into our DNA? Like, is there any study of that?
It comes out again into the cytoplasm and then leaves the cell, destroys the cell. We're talking about a target cell like the CD4 lymphocyte. It eventually will start destroying that population of cells, leaving those cells, invading other healthy cells. But one of the things that was really quite puzzling about all of this was this long latency period, because there were no known retroviruses that affected humans. In fact, there was only one that even was recognized to infect animals when AIDS burst on the scene. It was truly a shock and a surprise that there was a virus that could do this sort of thing in people. And, as we talk about sometimes, there are other viral illnesses that can be sustained. Many viral illnesses never go away. Epstein-Barr virus, hepatitis B, we can't really get rid of them, regardless of the host response. Some viruses come and go quickly, like the common cold and hopefully COVID do that. And then some viruses come, get quiet, and then reemerge and cause illness later, maybe years and years later, like chickenpox virus that later causes herpes zoster. So, the viral spectrum of illness is vast, and it's much bigger than we currently fully understand, that's for sure. And so there's a lot of new information that will be coming about viruses and all the things that they can do.
Well, what happens in a cell when HIV infects it and it becomes part of the DNA, it makes replicants of itself, and those replicants leave? Does it destroy the cell, or does it keep the cell in a state where it can produce multiple rounds of replicants but still survive?
Well, it's thought that it destroys that cell and invades other healthier cells. And the test that we do to measure the viral load is a test that we do on plasma. And this is a way of detecting circulating HIV in the blood. And of course, if we're fully suppressing it, that prevents, theoretically at least, cells from getting infected by other cells, because the virus has to leave the cell that it's destroying to invade a healthy cell, and it should be detectable in the serum. So when we're not detecting it, what we think we're doing is arresting the whole infection, not clearing it, not curing it, but arresting it in an important element that it has, which is cell-to-cell transmission of the virus.
You know what happens to the original virus that infects and endogenizes in the DNA? Does it stay behind, or does it leave too? I know maybe it's not even important, but I was just wondering what happens to the original one.
I'm not sure that that's entirely understood. I think it is felt that when the virus leaves the DNA, the cell is more or less at that time destroyed. So there isn't and cells don't live that long in the first place. There isn't a cell that's living for decades, generating more viral replicants. So I would just envision this as the virus enters the cell, gets reverse transcribed into the cellular DNA, stays there for a while quietly, then starts replicating itself. And when that replication begins, enters the cytoplasm with the replicant viruses and then destroys the cell.
Well, what would cause, you said these infections are latent for sometimes a decade. So has there been any conditions that people have identified that would that cause HIV to activate?
Well, only in a crude sense. Immunosuppressive therapy is thought to maybe accelerate that whole process, going from seroconversion to full-blown AIDS. So corticosteroids, perhaps. But it's a virus that's sort of doing its own thing, regardless of what the host immune system is trying to do. Now, if you have an immune disease, like, for example, lymphoma, where there is sort of replacement of the normal lymphocytes by malignant lymphocytes could be infected by this. They would have a very different kind of life than a normal lymphocyte would. They would not have suppressor interference by other cells and could potentially make the viral replication speed up. But, I think as interesting as that kind of theory sounds, I don't think that there's been data to really suggest that happens. I think when HIV goes from infection to AIDS quickly, that's typically in young children that happens. And that's because the cellular immune system in young children is not fully formed in the first place. So if you install something that is attacking it, and the cellular immune system, those lymphocytes have a very limited life expectancy to begin with because it's a young child, then the destruction can move more rapidly across the entire system.
Puzzling, yeah. Typically what would happen in people with AIDS is, again, they would be infected at some point. It may go quiet for months, years, maybe even a decade. Then they would start to they would start to get all these strange illnesses that they normally, I guess, quote unquote, shouldn't get.
Right. At that point, they would come to medical attention because they had one of these manifestations of really profound cellular immune dysfunction and destruction. And, that virtually never just takes months or weeks. It takes years in virtually everybody except the very young child. So it'd be common. I think the average in retrospect is 10 years between infection and AIDS. And now, even when someone presents to us with AIDS and an opportunistic infection, a person who may have never known that they had HIV infection for 10 years, when we treat even them, we can bring it all under control again. We can restore their immune system. We can typically eradicate quickly any opportunistic infection that's come along and stabilize them on an antiretroviral combination. And that's how many of those 1,500 patients we're following in clinic started out. They came to us not simply because they had tested positive for HIV, but because they had AIDS and were hospitalized with it. And then we were able to introduce treatment. So this strategy now of treating anyone with HIV infection, regardless of how long they've had it, and regardless of what opportunistic infections we're trying to eradicate, treating them quickly within a couple of weeks is crucially important. And it's been incredibly successful to do that.
So in the diseases that people would get, was there any, were there major groups of diseases that people would get in different populations, or was it a whole basket full of things that were apparently random?
Well, pneumocystis carinii pneumonia, that parasitic pneumonia, was always the number one opportunistic infection. And at one point in the 80s, I remember a publication indicating that 70% of AIDS patients presented with pneumocystis pneumonia. And at that point, some work was done on it, and it was found that many of us, probably most of us, at least in this part of the world, have a dormant pneumocystis infection. It's an innocent, innocuous organism that doesn't do any harm until you start subtracting the cellular immune system that normally contains it. Then it explodes into a very, very aggressive pneumonia. And this is what many AIDS patients in the 1980s, 1990s died of, because they could be difficult to stabilize once they came in with severe pneumonia, profound hypoxemia. The other, bellwether organisms were toxoplasmosis, that parasite infects the brain. Those patients would present with stroke syndromes, and on CAT scan and MRI of the head, they would have these large abscesses caused by that parasite. And as horrible as that sounds and as horrible as it looks, it actually responds to oral therapy. And the abscesses heal, they go away, and the neurologic deficits get better and go away. Cryptococcal infection, which is a yeast infection that is quite commonly encountered, but rarely produces disease, could cause an explosive meningitis. And it has a special predilection for the central nervous system. That was the third commonest organism that we saw. And I'll never forget one case of a young man who was moving from Michigan to New York. He drove from Michigan to New York, was able to drive most of the way, got to New York, immediately became very ill, became unconscious within a few hours, was brought to the emergency room, was brought to our ICU, was recognized as having cryptococcal meningitis, and was dead within 24 hours of leaving Michigan. He turned out to be HIV positive, never knew he was, had a very advanced degree of immunodeficiency, immune destruction, and was overwhelmed by that organism. But I could, spend hours giving you various patient examples of how people presented and were affected by this. But one really important thing to remember, and it's really important globally, is the relationship between HIV and tuberculosis. As with those other organisms I've mentioned, tuberculosis, Mycobacterium tuberculi, is contained by cellular immunity. If you are infected with TB, there's only a 10% chance you will ever actually get clinical disease with TB. Nonetheless, it kills over 1 million people a year worldwide. And one particularly nasty combination, therefore, is to have HIV and have dormant tuberculosis at the same time, because as the cellular immune system is destroyed by HIV, your protection against progression of tuberculosis is eliminated. And then you progress with TB. And it's particularly difficult sometimes to control TB in the setting of profound immunodeficiency caused by HIV.
Interesting. Even though I guess we have, approximately 8% of our DNA is endogenized retroviruses, up until HIV, there was no known human retrovirus that was found anywhere?
Yeah.
Wow.
Yeah, there was the simian virus that was had been recognized shortly before the outbreak of HIV. But, to give you an example of how this snuck up on us, I was a resident in Boston in the late 70s, and I was taking care of a gay man in clinic who had very large swollen lymph nodes everywhere and fever. And he was otherwise doing reasonably well, but we could not understand what those lymph nodes were from. We did biopsies, it didn't reveal anything. But by the time AIDS exploded a couple of years later, in retrospect, it was obvious that he had HIV infection, and that was what was causing this problem. As I think of people who were practicing ID or, looking at AIDS in the early 80s, many of us would have recollections of cases that, wait, you know what? That patient that I had 2, 3, 4, 5 years ago probably had AIDS, and it's an important, reminder of how, insidious something can be. Right now, we're dealing with an explosive outbreak of COVID, and that's one version of a global problem. But there's also the insidious problems, something like HIV that's transmitted quietly, that exists quietly for a long time and presents suddenly dramatically after it's had a long opportunity to spread throughout a population.
Yeah, very interesting. What's new in the frontier in AIDS research? Is it going quiet now that it's essentially treatable and it could be a lifelong condition that you can be treated for? Or, what are the new arms of research look like?
That's taken the urgency away from vaccine development, but there's still interest in that. That's an area that Dr. Fauci has been a pioneer and a leader in, development of vaccine. But as he and others have pointed out, when we start talking about COVID vaccines, HIV, they've been working on a vaccine for 35 years. They still don't have one. So that's a front that is still getting attention. But because this is a disease that requires lifelong treatment, as you might guess, there are efforts to make the treatment much more convenient. So instead of taking, for example, back in the 80s, it would not be unusual to have a person take 16 tablets a day on various dosing schedules to get all these medications in. And what's happened since then is they've steadily developed combination medications and medications that only need to be given once a day. What they're looking at now is more long-term medications, maybe parenteral, like injection medications that could be given maybe once a year or every 6 months. So that's where the forefront is. And until somebody develops a vaccine, that's where the progress is going to occur. Now, I would say, we have for 10 years had a project in Ethiopia. And what I'm saying about HIV care in the United States and in the Western countries and the developed Asian countries, that's what I'm describing. In the underdeveloped world, AIDS is still a tremendous problem because of the difficulty in obtaining these drugs. The Clinton Foundation has been very important in PEPFAR, the Bush effort to provide AIDS drugs to Africa. But it's still, when you're in an environment where people don't have easy transportation, where they may have to pay for their medications rather than getting them reimbursed by government, as it's usually done here, it raises these obstacles to care that are tragic. So it's not as though what I'm describing in our country is what's happening all over the world. There's still a high death rate. It's come down, but it's still unacceptably high death rate around the world from HIV, particularly true in Africa and in Southeast Asia.
And now you've turned to what, working on COVID?
Mm-hmm, right.
Okay. Any other parallels you're seeing between the two? Seems like there's a lot. I just wonder if there's other ones.
I think, one parallel that is in favor of COVID is that HIV was tragically associated with behavioral risks like homosexual activity, IV drug abuse. And for that reason, politically, it was swept under the carpet way too long and way too much. I think President Reagan never mentioned the term AIDS throughout his 8 years, and it was then that it was really exploding. Whereas COVID, since it hits the entire population, it obviously hits people who are in in minority groups and in impoverished neighborhoods even harder. But it is a fearful outbreak that's affecting everybody. So it is not buried the way HIV was, not hidden the way HIV was. Also, we have obviously very rapid development of diagnostic tests for COVID. It's not something that hides in the body for many, many years and then pops up. But one other parallel is when you're infected with COVID, the active viral infection is over in about 2 weeks, but we're learning more and more about the damage that it leaves behind. So those patients who have had COVID, many of them will continue to have pulmonary problems, cardiac problems, renal problems after that initial infection. So although it's unlike HIV in terms of the natural history of the infection itself, we may be accumulating a lot of people who have recovered from COVID who are going to need very specific types of medical care to deal with their organ complications from their COVID infection. One other thing is that with HIV, there is, of course, has been no vaccine. With COVID, there's tremendous effort to produce safe and effective vaccines, but it raises this issue of how effective does a vaccine have to be in order to actually achieve herd immunity and actually be a meaningful step in the right direction. So we've had the sad luxury of not having to deal with that question with HIV. So there is no vaccine, so you don't have to tell people, well, if you've been vaccinated, you can now have unsafe sex. But with COVID, since the FDA minimum effectiveness that has to be demonstrated for any new COVID vaccine is only 50% protection, there are going to be lots of people who are vaccinated against COVID who really don't have immunity to the virus. So what exactly are they supposed to do? Are we supposed to measure whether they have immunity, or is everybody supposed to continue using personal protective equipment? It's very different, but it raises some issues that are quite common to infectious diseases in general. And I'll make one last point about that. One of the infectious diseases that has been remarkably easy to control with vaccination has been measles. But that's only remarkably easy when people are getting vaccinated. There is a strong variable, but sometimes very strong anti-vax sentiment against measles vaccination and some of the other childhood vaccines. And we've seen outbreaks of measles in this country, but even more importantly, there are millions of cases globally of measles, a vaccine preventable disease. So it's hopeful to speculate that a vaccine to COVID or a vaccine to HIV is going to bring the end of something. But nothing is that simple in clinical medicine. People actually have to be willing to take a vaccine, and it has to be demonstrated to be safe. So we have multiple hills that have to be conquered before we get COVID under control. And there are some lessons from HIV.
Yeah, just like it's been 35 years with no HIV vaccine, COVID being a coronavirus, there doesn't seem to be any vaccines for any coronaviruses either. So
yeah, well, there was a
hope
vaccine
that it may be,
the original SARS outbreak in 2003. They did develop a vaccine, but only after SARS was gone, from the world. So this timetable, which is a little, frighteningly quick, this quick development of vaccines, may be a good thing because we will still have plenty of infections that need to be prevented by vaccination. It's really estimated that in this country, with all we hear about COVID every day, that only about 10% of the US population is immune. So that's 90% of the population that's still susceptible to this. So unless the virus magically transforms into a harmless virus, and there's not much evidence that that's happening, vaccine is the only out. So we have to hope that these vaccines that are being developed, and they're very, very different mechanisms to the different vaccines, will turn out to be safe and effective and usable, that there will be vaccines that can be distributed conveniently. Hopefully will not have to be given annually, but we don't even know that yet.
Well, very good. Well, Joseph, what's the best way for people to find out more about your current work and your past work?
I think there's some information in the bio on your page. I don't have it in front of me. I don't remember if the PubMed connection is there. PubMed is a good place to look for anybody's. It's a national medical library website. So that's a good place to look for work that I've done. And ResearchGate, that site where researchers share ideas. I'm on that site as well. And that's a good place to look for anybody's work. It's just called ResearchGate. So those are my ideas about how you might be able to find out more about what I've done.
Excellent. Great. Well, Joseph, thanks for coming back again. I really appreciate it.
My pleasure. Anytime.
If you like this podcast, please click the link in the description to subscribe and review us on iTunes.
You've been listening to the Finding Genius podcast with Richard Jacobs. If you like what you hear, be sure to review and subscribe to the Finding Genius podcast on iTunes or wherever you listen to podcasts. And want to be smarter than everybody else? Become a premium member at findinggeniuspodcast.com. This podcast is for information only. No advice of any kind is being given. Any action you take or don't take as a result of listening is your sole responsibility. Consult professionals when advice is needed.